Hello, and welcome to the UMKC Truman Medical Center Gastrointestinal Endoscopy Anticoagulation Guidelines. This brief video will introduce you to the guidelines, explain the information required to use the guidelines, explore the various sections, and demonstrate how to use the guidelines with two example cases. Introduction to the guidelines. On this slide, you will see the complete anticoagulation guidelines. The key sections from left to right are risk for bleeding complications, separated into low and high risk procedures, holding anticoagulation for GI endoscopy procedures, which lists the rules for if anticoagulation needs to be held, and if so, then for how long before the procedure. Next to that, you will notice the restarting anticoagulation after GI endoscopy procedures. And on the far right, you will see the guidelines for holding specific anticoagulation in the setting of impaired renal function. Using the guidelines. Before you can start using the guidelines, there is some key information required. First, is the patient currently taking any type of anticoagulation? If yes, you must first determine what type of anticoagulation they are on. Second, does the patient have impaired renal function? If so, their GFR and creatinine clearance will be important to know. Finally, what type of procedure will be performed? Procedure risk. The various GI procedures are grouped into two risk levels, low risk and high risk. Some examples of low risk procedures include EGD with biopsies, ERCP without sphincterotomy, or enteral stent deployment without dilation. Some examples of high risk procedures include EGD with dilation, polypectomy, or endoscopic mucosal resection. Here you can see the absolute risk of bleeding for each procedure. Anticoagulation. The various types of anticoagulation addressed in this guideline include aspirin and NSAIDs, thienopyridines, dual antiplatelet therapy, vitamin K antagonists, direct thrombin inhibitors, factor Xa inhibitors, glycoprotein 2B3A inhibitors, unfractionated heparin, and low molecular weight heparin. Stopping anticoagulation. Now that you know what type of procedure will be done, the bleeding risk level, and the type of anticoagulation, it is time to determine whether anticoagulation needs to be paused, and if so, for how long. For patients taking either a direct thrombin inhibitor or a factor Xa inhibitor, you will notice that medication will need to be held based on the patient's renal function, and you are directed to consult the table to the right. For patients with impaired renal function, the length of time to hold Pradaxa will be based on their GFR. For patients taking a Xa inhibitor, we will base this decision on their creatinine clearance. Restarting anticoagulation. For patients taking anticoagulation who were instructed to hold their medication before the procedure, you will refer to this section to decide at what point you may safely restart anticoagulation. Once again, you will make this decision based on the risk level of the procedure. In the next few slides, we will explore two examples of how to use the guidelines. Example 1. A patient with no known kidney disease who is currently taking Plavix is scheduled to undergo a screening colonoscopy. First, we consult our Risk for Bleeding Complications section and find colonoscopy plus biopsies under the Low Risk Procedure list. Next, we look for Plavix under Holding Anticoagulation for GI endoscopy procedures and find it towards the top under Dienopyridines. Here, we see that there is no need to hold Plavix for this low-risk procedure. However, we must warn the patient that if any polyps were to be discovered, they would have to be removed at a later date after holding anticoagulation. Example 2. A patient with chronic kidney disease, not on hemodialysis, with a GFR of 37, who is currently taking Pradaxa, is scheduled to undergo laser ablation. Here we see that laser ablation is considered a high-risk procedure. We will find Pradaxa under the Direct Thrombin Inhibitors heading and notice that we should consult the section to the right due to the patient's impaired renal function. The chart on the right side of the guideline sheet informs us that this patient, with a GFR of 37, who will undergo a high-risk procedure, should hold Pradaxa for 4 days. Finally, we consult the Restarting Anticoagulation section to determine when it will be safe to restart Pradaxa. Here we discover that we should hold it for 48 hours after the procedure. Thank you for watching this video, and I hope that you will now feel more comfortable using evidence-based guidelines to start and stop anticoagulation before GI endoscopic procedures.